Yeah. Okay.
Okay, so let's begin. Good morning and welcome to this HOI talk. Today we'll be talking about the East African health sector to try to understand some of the overall trends, including what the sector is looking for in terms of innovations, technologies, products, but also to discuss how innovation occurs in the sector in general. This is a complicated topic, and therefore I am particularly happy that today's speaker is Dr. Ian Clarke. Ian has spent most of his career in East African. He is an entrepreneur, a politician. He is the founder of several different hospital initiatives. But Ian, your list of achievements is long, so I'll let you present yourself once you're on. As for the format of today, we will stick to the usual drill. That is 20 to 25 minutes presentation from Ian, followed by 15 to 20 minutes of questions from you. For your questions, you can raise your digital hand or pose a question in the chat. I also need to say that we're recording the session, as we know that the people who are not available this morning, they will go in and listen to it on another occasion. I think that is it from my side, but thank you very much for joining us today, Ian, and I will hand over the screen to you.
Thank you very much. It's my pleasure to be here. As you can see, I don't have dark skin, so probably wasn't born in Uganda, but I've been here. I'm actually of Irish descent. So I'm an Irish Ugandan. I've lived here for 35 years. That's why I was introduced as having a fairly long, had a long history. So I first came out, just to give you a little bit of the background of Uganda as a country. I don't know, are you well familiar with Uganda, or I should give you a little bit more info?
Some of us are, but you better give a small background, yeah.
Yeah, small background. In between, Uganda got its independence in 1961, 2, okay, so in 62. And then it had been a British protectorate before that, and it went through a period when it had a prime minister and a president, and then there was a falling out between them, and the result of that was that Idi Amin came into power between 1972 and 1978, I think. After that, they tried to sort things out, but it ended up in 82, there was another civil war. So between 82 and 86, there was a war in a place called the Luwero Triangle. And that resulted in the person who's the present president, Yoweri Kaguta Museveni, taking power and setting up a democratic government. So he's been in power now since 1986. And I first set foot in Uganda in 1987. As a doctor, Uganda was experiencing a lot of issues at that stage, not least among them was the AIDS epidemic. And there was a lot of HIV, was this new autoimmune, or not autoimmune, but the immune deficiency had been found, especially in this area of East Africa, Central Africa, and it was decimating the population. So I came out for a visit at that time, and I was working as a general practitioner in Northern Ireland then, so I was part of the British system. I thought I could be more useful in Uganda. So I came out with a church mission organization. There's an Anglican mission called Church Mission Society. Came out with them and to do really community health work and primary health care in this place called the Luwero Triangle, where Museveni had where the Bush War had been fought. So it was grappling at that time with two things. One was post-war. The place had been fairly devastated, and the second one was HIV epidemic. During the first period of my sojourn here, I didn't come out intending to spend 35 years. But I came out, I thought, for maybe 2 years or that kind of time. But then we got very absorbed in the work because we were really kind of at the epicenter of the AIDS epidemic. And I said 6 years, and we started a clinic, but there was no referral. There's no point in having primary health care doing this sort of barefoot doctor type of stuff if you've nowhere to refer your patients to. And I spent some hairy times ferrying patients in my little Suzuki Jeep for about 2.5 hours into Kampala for cesarean sections and stuff where they needed a medical intervention. The result was that I appealed for money and ended up building a clinic, which became a hospital, so a small district hospital. And then I had to leave that project. So that hospital was established under really the faith-based or the voluntary sector, and is part of a whole network of hospitals throughout Uganda, which are under the Catholic Church, the Protestant Church, or the Muslim faith, and a few under Seventh-day Adventists as well. Subsequent to that, I came back. I stayed in London, did a master's in public health. Didn't really feel I could settle back to life in normal practice in England at the time. So came back out to Uganda. And Uganda, by this stage, this was about 96, had about 10 years of peace. And it was the economy was growing. They had stabilized runaway inflation. The country was in a very hopeful stage at this point. It was, the democratically elected government. Museveni was voted in, and the health system they're really trying to rehabilitate it. So coming back to Kampala in 86, I had tried to get some work with aid agencies, and I didn't seem to be a good fit, probably because I'm too much of an entrepreneur or something. So I just started another clinic in Kampala, but this time not with any support from any organization. But my focus was to see if I could treat the emerging urban middle class. Now, when I say middle class, it wasn't that they were earning European salaries or anything, but people had at that stage at least jobs which could provide them a living, with banks, with aid agencies, with telecom companies, with the developing corporate sector, and embassies and so on. And some of these organizations even provided medical insurance. So I thought, let me set up a clinic, and then if I can develop a surplus, I will use that to build a hospital, because there was no, at that stage in 1996, there was no private hospital in Uganda. So there were clinics, there were primary care centers, but there was no private hospital. And the facilities in the government hospital were fairly limited. But I remember thinking to myself back then, a resource-poor country doesn't necessarily mean that it has to be bad practice. You can still do evidence-based medicine, you can still have good hygiene, you can still make the best of the resources that you've got. And so that was really that was my thinking then, was that I'll do something that at least will be a model and will help to train Ugandans. So I did that. I first of all rented I first of all started with a practice, primary care practice in the city, and people paid me for my services. And then from that, I developed a small 30-bed hospital. Really from self-generated resources. And so I went from having a sort of two-man practice to having a little hospital with 30 beds, and I'm probably employing about 130 people in that. And the model worked okay. I was selling my service, and I was like any business, I was reinvesting the money back into the development of the business. One of the business models that I hit on at that time was to do what I would call a capitation payments. Now, it was kind of medical insurance, but it wasn't. Basically, it was a membership of my clinic or my hospital. So the first customer I had was the US Embassy. US Embassy realized they had expensive international medical insurance for their expatriate employees, but for their local employees, their local hires, they used to, go to a clinic, bring a receipt back, get a reimbursement. And the HR manager, said, well, this isn't very manageable because we don't really know what our budget or medical budget is going to be. And it wasn't that it was costing him a lot of money, but he wanted to standardize it. So he said, I'll pay you, at that stage, it was $160 per employee per year for me to provide their medical care. And I said, fine. And I don't know how many the employees they had, but I was working on the basis that I already had a lot of certain fixed costs in my hospital or my clinic, and this company would then my costs for bringing in another 300 patients or whatever and getting a sort of quarterly check for them were only my marginal costs, which were buying drugs and laboratory agents if I had to pay any more doctors. But I was already basically paying doctors and nurses, and I was there myself to do the service. So that model actually helped me then to grow the business, because the other companies started to join my clinic and my hospital. And then I started to promote it and have a sales team that did that. So from that, I then grew to several clinics. And then from that, I decided that the small hospital I had was inadequate, and got a bank loan. Remember, I got $1 million from the European Investment Bank at the time through Barclays Bank that existed then, and got that at a very reasonable interest rate, which was 7.2% on the shilling, which I know in Europe, where you've got interest rates. Well, now I think the British interest rates just gone up to 4.5%. Where your interest rates are generally low, but the interest rates, as you may know, in Africa are astronomically high. So to get it at 7.2% on the local currency was excellent, because the local currency itself would always depreciate quite a bit over the years. So you had monetary inflation and then actual inflation. So I got this loan, bought some property, gained some more companies, and was able to make the transition from 30 beds to 100 beds. After that, hello. Okay. Subsequent to that,
oh, somebody has to mute. I don't know why there's an echo.
There was a feedback. Subsequent to that, by the way, this process was going on over about 15 years, or I can't remember exactly, but I told you 96. So now we're in 2013. So it wasn't a fast process. It was fast enough for me, but so I would say by the time I bought the new site and so on, I was maybe 8 years into the business or something. I developed this new 100-bed hospital, but I was running out of cash, and so I then looked around for private equity, for an equity partner, and took in a private equity stake of about 35% into the hospital with a Mauritius company. They invested in me, and then after about 3 to 4 years, they exited, and a major about 8 or 10 years ago, 8 plus years ago, 8 to 10 years ago, then a large company from Mauritius actually bought the operation. So at that stage, it was the HMO, the membership organization. It was about 15 clinics, and it was a 100-bed hospital. And it was all in the private sector. There was no subsidies for it. Our mix of payment for the organization was a lot of it was, by that stage, if I go back to about 10 years ago, was by insurance companies, medical insurance, the HMO business that we had ourselves, and cash in the clinics was quite small, but cash in the hospital was probably maybe about 30% or something like that. No, so that's my journey. I also started a clinic in South Sudan, which I didn't sell that one. I still run, and I still have medical insurance in South Sudan. But now I'm just a minority shareholder in the hospital business. Along the line of the way, I started a health science university, which has transitioned now into a general university called Clarke International University. And then we've got into education. We've done a primary school. Most recently, after I sold the hospital, I have developed a coffee farm. That's how John Magny knows me. So that's I'm more diversified now. Now, in terms of the health business in Africa, it depends which country you're in. Nairobi has got, I would say, tier 1, tier 2, and tier 3 hospitals. Their tier 1 hospitals, such as Nairobi Hospital and Aga Khan Hospital, tend to be not much different in price from your sort of British private medical care. So it's quite expensive. And the tier 2 hospitals are more for the local. They're fairly good. And then then the rest. In Uganda, I would say we're really tier 2, a bit of tier 1, but more tier 2, meaning that if you have a car accident, or you need trauma surgery, or you need intensive care, we'll be able to handle it okay here in Uganda. But if you get into more super specialist care, we may not be able to do it right now. To me, the problem for medical care, for healthcare in Africa it's just people's ability to pay. Because even if my I would say International Hospital, the group that I built, their charges were not very high in sort of dollar or euro terms, but still, if somebody gets a bill for 20,000 euros, even if that has been for a bunch, a very complex treatment, it's still way beyond what most people have provided for, unless they've taken medical insurance. And the medical insurance cover has limitations, but also only less than 2% of the population in Uganda is insured on private insurance. That has left, a lot of talk about national health insurance and plans to do that and bills before Parliament. But the problem is the difference is in the detail. And although we may, put in a statutory body to bring in a national health insurance scheme in Uganda, there's just very, very many issues on the ground. And again, it'll be the ability to pay. Kenya has got what they call a national hospital insurance scheme, which they started as very, very small contribution, and now they're slowly expanding it. Again, it has a lot of problems, but I think they're a little more realistic than some other countries. Rwanda has got 2 systems that work quite well, but Rwanda is an autocratic country, and people do what they're told in Rwanda. Tanzania has got a scheme that is hard to know how it'll work out. It benefits some people, but others don't. And South Africa is wrestling with the problem at the minute, because South Africa got about 20% of its population are covered on the private insurance, which is private hospitals, which are very good. But then that means, and apparently about 80% of health expenditure goes into about 20% of the population that are covered, whereas the other 80% of the population go to the public scheme, which are not terrible, but are variable. And you would say that sometimes about a lot of African health cover, it's sort of hit or miss. I have not subsequent, but over the period of time, I've been the chairman of the East Africa Healthcare Federation, representing the private sector. I've been involved, the chairman, I helped to set up the Uganda Healthcare Federation. But actually, now that I'm getting older, and I've just recently resigned from those positions, so I'm kind of got lots of knowledge now of the system. I have a bit of political influence. I was mayor of a section of Kampala at one stage, and I have a lot of. Sometimes I sit in various committees, but I'm kind of kind of moving away from the health sector, I would say, now at the present time. I think I've used my 20 minutes. Yeah, so I can happy to take any questions.
Okay, thank you for sharing all these interesting experiences that you have from the East African or Ugandan health sector. So please, if you have any questions, raise your hand or just interrupt or ask the question. We are a small group of people today. But in the meanwhile, I do have some questions. So in access to innovation, a lot of the companies that we work with, they develop products that are somehow health oriented. And in that innovation or product development process, how likely is it that they will be able to collaborate with hospitals in Uganda or East Africa? Do you know the hospitals, how many joint innovation projects do they engage in with the private sector?
I think there's a lot of startup type projects that are going on at the present time. I'm on the board of some of them. There's an organization called CTI, which has been developing a platform to monitor the health indicators both for individuals and what's going on in communities and for hospital electronic records and that kind of a thing. And they've got a very good platform. That kind of a thing can be very, very useful both for an individual hospital or if you were doing something like a health insurance, so trying to get universal health coverage. There's another startup where in using the MTN platform, this young chap has put up a wallet for clinic payments. But the advantage of his wallet is that if the person's saving small amounts onto that clinic payment wallet, and then they go to the clinic and they're short for payments, they can then get a little loan to make to pay the clinic, and then that comes off again. So such innovations, especially in the sort of health sector for data and payments, I think is very useful. There's also people who've done, now you can use a mobile phone and a probe, say, to do an ultrasound scan, and there's various other initiatives that are going on. I'm involved in an American company myself, where we are developing a surgical sterilizer for instruments that doesn't use heat and doesn't need power. And so therefore we generate nitrogen dioxide in the sterilizer, and then it gets scrubbed up, and so it can sit in a case. So it's very good for either emergency situations or for rural situations where you don't really have the power to run a sterilizer. So these things there's quite a lot of stuff around. It's a question often of, you feel like the ministries of health, which are the big players, are often very slow to react. And I get frustrated with, like, we have in Uganda a thing called the Uganda Cancer Institute, which has a glorious history of research, and they're stuck in their glorious history. It had a glorious history, and then it kind of crumbled. But of late, they've attracted hundreds of millions of dollars of grants to get the all singing, all dancing cyclotrons and PET scans and PET MRIs and all that. And I'm kind of thinking, that's fine, but in fact, most people die before they get to that point, because they can't get, they get tossed around in terms of having to get a biopsy, or getting early diagnosis of their cervical cancer, or even just getting their lump scanned and then biopsied, and to get it into the system. So you're getting all this really sophisticated stuff that will compete with some of the stuff you've got in Europe, and yet you've got a very, very, very poor referral pathway to it. So we're not solving the basic problems, and sometimes we're just a bit. I don't think the answer is a more sophisticated treatment. It's more early detection, more early diagnosis, more community education, all of that sort of stuff is where we should put in our resources. Somebody had their hand up there.
Yeah, Michael, there's a question from you.
Thank you, Ian, for this very nice presentation. and taking us through your journey. I just wanted to ask if do you have in East Africa, Kenya, Uganda, any programs regarding import tax? If a company wants to export or set up a business in Uganda, for instance, and then import medical stuff, equipment to Uganda, is there any kind of programs you can join as we see in the farmers sections or the farmers segment?
If you're importing medical equipment, there's no actual tax on it, but there will be some charges because they have so many different taxes. So you can say there's no excise duty, but then they'll have withholding tax and things like that. And then you sort of have obviously customs clearance charges. So to bring something in with absolutely no charges on it is unusual, but definitely for medical equipment, they're not going to be charging you the whole gambit of taxes. That's one of the exempt sectors. Yeah, medical equipment and drugs, as far as I'm aware. Yeah.
Thank you.
You mentioned, Ian, that the access to healthcare services depends very much on people's income level. So do you see a lot of products coming in that caters for the low income segment in terms of healthcare?
So, I mean, there's let's take drugs as an example. Most of the drugs that come in here are Indian manufactured. Some are Cyprus, some are Egypt. Some might be European, but I mean, even some drugs that are sort of European origin are still manufactured in India. The product, the original pharmaceutical product, comes from China almost always. But the cost of drugs coming in here is much cheaper than Europe. And certainly the initiator brands, the patent drugs, you can get them, but they will be much more expensive. So there's a sort of a whole different price category here that we are subject to than would be the case in Europe. And the drugs are generally, you do get a problem with fake drugs, but you can get that anywhere in the world. Maybe you've more of a problem in Africa, but they do have regulatory authorities and so on to try and control those sort of fake drugs. And then we also have some local manufacturers who make, most of them make the basics, certain antibiotics, painkillers, and so on. Some of them are, there's one factory here that is Cipla Quality Chemicals, which does ARVs and antimalarials and is WHO certified. But that's kind of a big process, apparently.
Thank you. There's a question from Aurel.
Yeah. Hi. Hello, everyone. Hi, Ian. Thanks for your presentation again. I'm kind of wondering if you can share some examples of innovations stemming from Denmark or, for that sake, European countries, small, medium companies that have successfully been able to implement their solution in Uganda or Kenya. Or have you had experiences with this over the years, working with hospitals? And yeah, maybe some one or two examples.
Now you've caught me off guard in terms of the medical innovations and with Europeans. But what I do know in the agricultural sector and the coffee sector, I just seem to, and even the tourism sector, I seem to meet a lot of Dutch people who are involved in innovations. For some reason, I don't know what's wrong with the Dutch, but
well,
there's a lot of good
tax
stuff.
thing, right? To get back to Michael, they have the Netherlands and Uganda have a good tax relations, as what I understand. But maybe then do you see some areas of opportunities for Danish companies or European companies to tap into here? I mean, maybe also speaking to the role
in my university, we did a project for IT, because you know there's a lot of IT graduates from Macquarie, which is a big university, but you find these IT graduates when they come out, they actually know nothing, you know, and so you have to retrain them, or not retrain, or to train them properly, and especially in, you know, areas such as coding, but even in social skills and confidence and all kinds of things. So we got some funding. There was a company called Laboremus set up here. It is, again, Dutch. There was a Dutch involvement in that one, yeah. And they collaborated with a guy called Michael Green in the UK, got some money there, and then got some funding from NORAD. Yeah, no, so I think the collaboration was Clarke International University, NORAD, and Laboremus. And we're able to then take on students who would do a 3 months intensive training course on IT, and then do a boot camp and designing something, whatever, a website or some solution, IT solution. And actually, almost all those people then went on, got jobs, or did stuff. And that was and that's continuing in the university, where we've developed that into a non-profit, and finding other funders. And because, you know, one of my employees was I mean, his history was he was an orphan, and then he was sponsored by one of these church groups that took, you know, they take African children around the world as a choir, and then, you know, they raise money and stuff. Like, he came through that sort of system, and then he trained, you know, he went to school, he trained. Don't know what he did in university, but he started to do finance. But he has become quite successful in actually selling his services, and we work, you know, on that kind of thing. So obviously there's a lot of opportunity to take young, bright Ugandans and then fine tune them to get them up to speed, that they can do some of this contract work that is going to be more expensive if you're sourcing it from Europe. And that's the, you know, that's
maybe if Thomas doesn't mind, you just named a bit of the role of the digital sector, and sort of a bit of a convergence with health. Also, there's a potential for that. That's acknowledged, for sure. Also in academia. Anyways, what type of role do you see, or like, for the potential of digital health solutions and technologies in Uganda, maybe also across the different types of healthcare providers? You named tier 1, 2, and 3.
Well, you know, I think, I mean, digital health, I mean, of course, digital and AI is the future anyway, but globally, but digital health in Uganda can do the whole sort of leapfrogging process that happened with mobile phones. And particularly if one has smartphones, then I think there's all sorts of possibilities opened up for. It's really what, you know, task shifting. For example, if you have an orthopedic problem, you've got a very few orthopedic surgeons serving the population. So when you say, you know, it's maybe one orthopedic surgeon in a whole district or something. But if you then bring in the digital platforms whereby you can do a decent, you do two things. One is you can use the digital platform actually to sort of bring the patient to the specialist, but then you can also use algorithms and basic training to bring someone who's not an orthopedic trained doctor, but if he's done a 3-year training in orthopedics as a clinical officer, and then he's got the right algorithms and so on, then he can actually then move up into the place of the orthopedic surgeon. So you can train a lot more such people. You can even train nurses. You know, so when you get to the point of both, you've got the algorithms, you've got now, I mean, if you take dermatology and radiology, you've got the ability through AI, you know, with AI is obviously training on so much more, that really now it's accepted that a digital readout on an X-ray is probably going to be better than a human being doing it. And so you can see that the issue in developing countries is that, you know, just reaching somewhere can be extremely expensive. You got to get a 4-wheel drive vehicle there, you know, so you have fuel costs, you have all of that. So if you can get to these hard to reach places digitally, or with a much lower trained health worker who's got the right platform and the algorithms, then you can see, you see what I'm saying. So I think that's the way it's going to go to bring some sort of equity in health services. And as I said earlier, we've got to be concentrating our resources more in the prevention and the early detection. There's much more bang for your buck than putting it into PET MRIs or this kind of thing. So yeah, I mean, digital and health is a big deal. We did quite a bit on digital innovations, where we paired up somebody who's a nurse working in ICU along with a tech guy. And they said, so what are the problems that, where are the issues here? What, that we need to bring a more efficient solution to, and how can we do it? And, they came up with some quite good stuff.
If you look at some of the international development organizations, for example, Red Cross or WFP and WHO, what they often do is that they identify a number of challenges, and then they expose these challenges into different kind of innovation initiatives, and kind of ask the private sector to come up with different types of solutions that can address these challenges. Now that you've been in the East African Healthcare Federation and involved in hospitals and stuff, and other types of clinics, do you know other initiatives, I would say more kind of East African driven initiatives where the health sector tries to identify challenges and match that with potential companies that has the capabilities of providing the solutions?
No, I think there's quite a lot going on. I'm not, I mean, you've got, if I take the three countries, Kenya, Uganda, and Rwanda, Rwanda, I think, has opened a tech hub, but it's heavily, I think, government driven, and it's probably, it's unlikely probably to become this kind of regional tech hub that the government would like it to be. Uganda's got some, individual stuff going on, some quite good stuff going, but with no government support at all. And the hub for technology is really Nairobi, because there's a lot of there's good support from the tech companies, the big tech companies there. I'm not sure. I think there's government support as well. So there are, I mentioned this company called CTI. So CTI, I'm on their advisory board, and it's an interesting company in that it's a guy sitting in New York who has been gone in and out of Africa for a long time. I first met him when we were flying back down from Juba to Entebbe. And he's looking at, he did some stuff in the fintech industry, made some money out of that, and then he's been looking at the healthcare side of things now for some years. And they've developed a platform that's been developed by Ugandan and Kenyan techies, and it does a whole dashboard, both for individual health and then for communities where the healthcare is given, and for hospitals and so on. Very, very appropriate, for what's needed. But what he needs now, or that company now needs, is for some government or some state to take it up and say, oh yeah, we'll pay you, for this, because and to me, I think that's where we've got to get the leap between the public and the private side. So you've got to get the government who says we want to do health insurance, but to do that we need the data. So which is the best data company to get? What's the best platform, and how can we do this? And we will pay you for it. It's all that. There's a lot of, in Uganda, bit fed up, like we started off hopefully with a president and a government which was really quite progressive, but once they got into this whole sort of rat race of so-called multi-party democracy, then we've just had pseudo elections and pseudo democracy for the last 20 years. So you don't, in such a political environment, then things aren't moving. Everybody's looking over the shoulder to see what State House wants, and you're not really, moving. Kenya's funny actually, because it has these, at least they got out of that same scenario that we're in. And now Kenya has, has to have a change of government at least every 10 years or something like that. But they have such divisive politics as well on the two sides, that, you know, that's why they have demonstrations and all that. So the politics affects, you know, what's happening as well, because you've got perfectly good solutions, but they're not being adopted because of political considerations. You understand? And those, you know, that's that. And so you're not moving forward in a sensible, coordinated way. You know, here's the solution, here's what we should be doing, but it's actually not being done because there are other considerations to be taken into account. But, you know, there's a lot of exciting stuff going on in the region, and you know, some in Uganda and more so in Kenya. And a lot of, I think in Nigeria as well, there's quite a lot of stuff going on.
Thank you. There's a question from Xavier. Is that rightly pronounced?
But yeah, thanks a lot. I think what's quite interesting is that you're mentioning the government now. I mean, health is a very regulated sector. And I can also imagine that, for example, when, testing your product or something, it's very important to have licenses to also make sure that your health product actually gets to the market. How is the situation in Kenya with the regulatory system? For example, I know that in Kenya, they have devolved it very recently to the county level, which has made a very different pathway of actually working around regulation. And also especially for Danish organizations, how is it working with the regulatory system, and what's your experience with that?
Well, you know, I'm in Uganda, not Kenya, but I know, you know, a bit about Kenya as well. And you're right in terms of the whole county system there now in Kenya. For Uganda, I mean, they have the regulatory bodies for everything. But you do, regulatory bodies to me then bring in this whole sort of rent-seeking thing where they sit on top of you and squeeze money out of you, not just for legitimate fees, but sometimes, you know, well, if you want to get this done, you know, we'll need some other facilitation. But they have, I mean, it's variable because, I mean, you have the, what do they call it? There's a committee for scientific research. I forgot what it's called, but it's a standard, you know, you usually have your university approval committee, and then it goes to the national committee. So for a research project, you'll go through that. Now for tech stuff, where you're just doing, you know, it's for a platform that's going to improve patient information or whatever. The laws, some of them are still being developed, but I mean, if you take the European laws, which you know, you have a lot of protection for we're supposed to have a lot of protection for the individual in terms of their data, then, you know, the same thing, you can assume the same thing would apply here. So for example, I mentioned this one, CTI. I mean, their thing is designed so the patient has control of the data. So the patient has to give the doctor the permission to actually use his data. But I don't think in terms of tech startups, there is a ministry of IT here as well, but they're more interested in squeezing more tax out of social platforms and stuff like that. So yeah, it's not. I don't find the regulatory thing. Like in my university, we have a higher education council, and they have to regulate all the courses. And sometimes it's like very old-fashioned, you know. And you're like, man, you know, this isn't really practical in terms of if you're going to. And so and the nursing council, I find the same thing with them. It's old-fashioned. It's not moved on. It should be 50 years ahead of where it's at, especially the nursing council. So that I think holds back development in countries such as mine, such as Uganda. But I think sometimes in terms of introducing innovations and so on, yes, there are hurdles, but they're no worse than they would be probably easier than they would be in Europe, I imagine.
Okay, thanks a lot. Yeah, I actually meant Uganda. Sorry.
Sorry, it's okay.
Okay, thank you very much. Time is running up. We have already passed the time. But Ian, thank you so much for sharing all your insights. It has been highly interesting. Yeah, thank you very much for that. For the next HOI talk, that will be the second week of next month, and we will post the topic and speaker soon. But thank you very much.
Welcome. Thank you, people.
And all the best to you.
Nice to talk to you.
Thank you.
Thank you.
Bye-bye.